like to invite K-lynn and Ashley up to the front, please, for our panel discussion. And we'll hopefully also have Alex and Sonia on the screen to participate as well. Alex, I have a question for you, if that's okay. We have a question asking, how much does the machine cost to make, how much does the machine to make the disinfectant cost? And how do you dispose of the little minims containers?
How do we dispose of minims containers?
Yeah.
We don't use minims.
Okay.
Minims are single-use little plastic droppers for eye drops. We have converted to bottles. So if you use a no-touch technique, if you hold the bottle above the patient and then it drops through air before it hits the eye, then you can do that. So we have a bottle of tropicamide and a bottle of proximethicane in each clinic room and swap them out once a month. Most rooms manage to get a month out of the bottle. If we do touch the patient or it gets contaminated, then we turf that bottle and get a fresh one out. A box of minims, which is 20 drops for proximethicane, is about, how much is it? It's $40. And a bottle of proximethicane is about $15. So actually, if you save 5 minims, it's cost effective to do it that way. So to answer that bit, we don't use minims. The machine that we've got costs $10,000. If you go on the website, the prices are right there. So ewco. And there's lots of different ones, and they all have their prices online. I think it's $4,900 US. I was on the website just the last couple of days. Then you have to pay shipping, and then there'll be import duties as well, local taxes. But that's how much the machine costs. So, and they do a range of machines that go from, ours is at the bottom end of the scale. It gets bigger and bigger and bigger and bigger and bigger from there.
Thanks very much, Alex. I think that definitely illustrates the sort of triple bottom line and environmentally better, probably also better for the patients in terms of reducing. Thanks so much for that. I have a couple more questions now. I'm going to maybe group a couple of questions for you, Ashley, if that's okay. So firstly, how did you come to the figure of 138 cubic meters of carbon per acute bed per day?
That was based on a study done in the US. So perhaps our acute care wards and intensive care wards could be comparable or not. I'm not sure. But it was a study done by Prasad et al., published in the Journal of Life Cycle Analysis. It seemed pretty comprehensive, so I used it as a reference.
Now, one more question for you, Ashley. Have the actions you implemented been transferred into other medical areas within where you work?
Other medical areas, like other medical departments? We haven't had any cross discussions, but in the day procedures unit at Fremantle regarding the bluey use, the reduction there, the gynecology department is on board with those changes. So a little bit in gynecology and day procedures unit. Yeah.
It's great to see some cross-pollination, and hopefully that'll continue to expand as well, plus a bit more of a top-down approach as well through executive. So, K-lynn, we've got a couple of questions for you. Again, I might just group these together because they kind of focus on similar areas. One is related to the information sources from your presentation. A few of them are not based in Australia. So
using things like OpenLCA, because you are using databases that across the world or economic information, you can use Australian specific information. We actually have the Australian Virtual Ecology Lab, which provides that information for an Australian specific context. So it allows you to use the energy and the sources of energy from the US. When you're doing an LCA, yeah, it's very much your own specific procedures. But you're right, Australia is a little bit behind the 8 ball in developing and adopting these tools. Now, the input-output, Mirio, that works for us because that's economics, and we actually contribute to that.
Okay. Thanks very much. And second question, and I guess this is kind of broadly to all of our speakers, really, what is being done in adaptation in your areas where you work? So this is relating to things like building and infrastructure resilience, staff wellbeing, and caring for those with the mental health impacts of climate change. And K-lynn, I've got you here, so I might ask you first.
That's actually mental health is a huge issue here in Australia, and it's finally becoming something that we have items we have support for. But climate change, and we know that youth are particularly affected by climate change, and particularly through COVID as well, in isolation. So, and eco anxiety. One of the big things that we see is talked before, social prescribing, not actually having a medical response to this, getting people out into nature, connecting people with other people. You know, I feel empowered by this, seeing all these people who are wanting to do something about climate change, doing things, you know, what they can do in their own patch and advocate for other examples. This is very empowering, and this is really good to see. And I think that us advocating for talking more about it and getting it is how we will actually address those mental health issues.
Well, because I know we've had a few discussions about this, Sonia and myself, about adaptation. What were your kind of views on this, Sonia, with regards to adaptation?
Specifically when it comes to workforce well-being, was that would?
Yeah, workforce well-being, but also building infrastructure resilience and mental health impacts.
So this aligns to some of my research actually on junior doctor well-being, but and one of the slides I had earlier about getting clinicians involved in initiatives is about improving their sense of control in a space where it feels like maybe we don't have influence or control. And I think getting clinicians, frontline clinicians of all levels, not just doctors, involved in grassroots change projects gives them a sense of control over a situation where they don't feel like they usually have control, give them a sense of pride, and Ashley might be able to talk to this, in the work produced when contributing to improving carbon footprint in your sphere of influence, and ultimately contributes to like general clinician well-being that is compounded by other organizational factors outside of the space. And so an organization, an executive team that sets up the resources and supports clinicians to be educated and participate in improvement projects in your spheres of influence, I think will go a long way in this space.
Yeah, excellent. I think a lot of the work that we've been doing is to try and reduce our carbon footprint, but it can sort of seem a little bit retrospective, like we're trying to work right now. And I don't think that there's enough work being done to project into the future what sort of workforce capabilities we're going to need. For example, for us, we expect a lot of heat waves, longer days, people having less water, dehydration, kidney stones. If we had a 20% increase in the amount of kidney stones that we're presenting to the emergency department, I don't really think that our workforce right now is cut out to deal with that amount of operations. We would need to increase theatre time, nursing time. It's a cascading thing. So we would need to project into the future, hire accordingly, train accordingly, and increase our facilities. But I don't really see it happening at this stage.
Broad-ish question, and I might direct it briefly to Ashley and Alex. Briefly, what do patients feel about the changes that have been made?
Oh, I was gonna say, you take this one, Ashley. I think.
I think that a lot of what we do is trying to increase efficiency, and then so in terms of like travel or clinic time or time in hospital and that, or telehealth, for patients that just seems like it's a better utilization of their time. They feel like their time's being valued, and I think that they really appreciate that. I don't really think that they see the green side of it. I'm working on a project where I hope one of my outcomes will be to actually discuss with patients two options and provide them with a greener footprint for each of the options, and say, which one would you prefer? From a medical outcome perspective, it'll be the same, but you have a bit more autonomy in your choice. I think that's the next step with patients' empowerment. If it doesn't change their medical outcome, they could have more choice in what they choose to have in the hospital system.
Great. Alex, from your perspective, patient impacts and how they see the service changing, did you have any comments on that?
Yes, I think given that this is a forum about people and doing the changes, I would say that we'd done loads of changes. I mean, we sat down and everybody wrote a list of all the things we'd done, and we were all remembering things that we'd done, and we couldn't remember what we'd done. Essentially, patients, the first time we did solar powered surgery, patients didn't know. It was about 2 months later, I said to a patient in the post-op room, oh, and that operation was solar powered. And she turned around and looked at me and said, beg your pardon? And they didn't know. And I think, you know, unless you actually explain that these are the things that they are getting, people will not understand. And I think we make a lot of assumptions about what people are thinking that we're doing. But if we're doing these things and not explaining that we're doing these things for people, then they simply won't appreciate them. It's overwhelmingly positive. Everybody gets it. There are no more climate deniers. Everybody's very appreciative of us making an effort, and they all absolutely love being part of that as well. But unless they actually understand that that's what's going on, I think we have to actually find a way, if you're doing these things, tell people why you're doing them and tell them what the benefits that they're doing are by coming here, or by doing a clinic which you only come to once. Then we're saving, you know, so many thousands of kilograms of thing. And it's a very nice line to come out with. If somebody's been waiting 2 hours in your clinic, you say this is a one-stop clinic, and we're saving this much time, and you know, you would have had to drive home and then come back again another day if we weren't doing it like this. And so there's a lot of positives, and people are generally very, very happy to have that explained to them and feel better for it as well. But I think we're all a bit guilty of underserving people in that, not sharing what they are doing with them.
Thanks, Alex. I think that's actually answered some of my next question, which was kind of directed more towards K-lynn and Sonia. So specifically with regards to the DEA, but also us as healthcare professionals, what can we be doing more, or what resources are available for us to educate our patients on climate change and what we're doing and what we can do better?
Making the right choice and not asking for things that are inappropriate. And I went to my doctor with acute back pain, hoping for a referral to physiotherapist. And he said, well, would you like an MRI? And I went, that's low value care. That's not going to be a diagnostic. What are you talking about? And he kind of looked chagrined and went, I know, but I thought that's what you wanted. And I'm like, oh, okay. So I think having those, so for GPs, being brave and having those conversations, and as patients as well, expressing that I would like to know, what is the carbon footprint of this? What's my alternatives? Can I have something that would actually be less of a problem? You know, there are, I know that there are posters to put up for GPs. There's also Consumers Health Forum of Australia has questions that as a patient you should ask when you go to your GP about the procedures. And part of it is, you know, what's the impact of doing this? And more importantly, what's the impact of doing nothing? Could I just do nothing? Will this go away? And so, yeah, I think having those conversations and having brave conversations, as a lot of people are, is what we need to do. And celebrating, as Alex said, people are excited when they're part of something new that's really cool.
Yeah, and you know, I'm glad you mentioned the posters, because DEA members across the country have actually been working within their own interprofessional colleges with the sustainability committees and the education committees to make sure that we have up-to-date education materials for our health professionals already working in the field, as well as patients. So RIGP is a leader in this space with posters and information for their clinicians as well as patients. And then RICP is also leading the way. Many of you might have attended the DEA AMA webinar that Archana actually did present at as well, asking all specialty colleges across the country to highlight what they're doing in the sustainability space. So I'd encourage you all to kind of take a step back, go back to your college websites, type in sustainability and see what resources are available for you. From a DEA perspective, Kate Wiley, who's a GP and the executive director of DEA, actually hosts a webinar that's, I think, runs on a quarterly basis, that's accredited for CPD points from RICGP and ACRM. And so again, that's continuing professional development and education for our senior clinicians across the country to tune in and upskill themselves on what to do in this space. And I'm more than happy to work with leads across the country to see where the gaps are and when it comes to education and professional development and help fill them.
I'm going to take 10 seconds to answer the one on anesthetics because it's the top question. What are the barriers for changing our anesthetics and more environmentally friendly options? Why don't we just make the change? We've just delisted desflurane from the WA formulary. So that's step one. Step two is we're working on it with the college and at a national level as well. So you'll see some information in the National Climate and Health Strategy about this. We're getting there. Thank you so much, everybody. And thank you to all of our speakers.